Thank you, Meg, and thank you, Dr. Crane, for joining us. I'm very excited and honored to have you here with us today to help us learn more about how pain can turn into chronic pain and CRPS specifically. So thank you for joining us, and thank you all for joining us today. I guess to kick it off, we could start with, what is chronic regional pain syndrome? Oh. Can you hear me?
Are you directing that question to me, Dana?
Yes.
Oh, I'm sorry.
It's you and me, Dr. Crane.
Got it. Okay, I didn't understand that. Well, what is complex regional pain syndrome? It's a chronic pain syndrome that usually starts off with minor or trivial injury, or sometimes a more significant injury. It comes in two flavors, type 1 and type 2. Type 1 is not associated with a known nerve injury. Might be associated with a twisted ankle or surgery on the ankle or the wrist or the hand, etc. Usually something fairly minor. Type 2 is associated with a known nerve injury, though this may be a false distinction, because it may be that type 1, in fact, is associated with nerve injuries, but nerve injuries that are just too small to recognize, small microscopic nerves, for example, or small branches of nerves rather than large nerve trunks that are usually associated with type 2. So anyway, it's a syndrome that occurs after presumably some nerves, either tiny nerves that are too small to see or difficult to see, or large nerves that are easy to see, are injured in some fashion. The pain is different than the pain of the injury itself. I have a colleague who's an orthopedic surgeon who's prone to CRPS. He's also an avid runner. He's actually a trail runner. So as a trail runner runs, they twist their ankles a lot. And when my friend Larry twists his ankle, he will often develop CRPS. And he has told me that he can almost pinpoint the day and the hour at which the pain changes from twisted ankle pain, sprain, to CRPS pain. Why that occurs, don't really know, but it's a distinct kind of pain. So it's a neuropathic pain. It's a pain associated with nerve injury or nerve inflammation or just misfiring nerves. And as neuropathic pain goes, it has several characteristics that are unique. It's typically burning pain. It's typically a shooting pain. It's very severe. The pain is spontaneous, which means it doesn't just occur when the affected body part is touched or moved, but it's there all the time. It's associated with hyperalgesia. Hyperalgesia means that sensations that normally are painful or uncomfortable are even more painful. So if you were to touch the skin with a pin or warm it with hot water, the pain would be amplified way above what would normally be expected from that stimulation. It's also associated with allodynia. Allodynia is the term that's used to describe pain that occurs with sensations that are not associated with pain. So light touch, for example, just the stroking of the skin with a piece of cotton, or the touch of a finger on the skin is oftentimes excruciatingly painful. I like to say that when a parent calls me on the telephone and for a consultation, and they are describing their son or their daughter having extreme pain in their foot or their ankle or something like that, I can practically make the diagnosis of CRPS by simply asking them to blow on that affected body part as if they were blowing out a birthday candle, a birthday cake. And when I can hear the child scream in the background, I pretty much know it's CRPS. Those are the acute symptoms that we see. More chronically, when it goes on for weeks, months, or even years, it's associated with dystonias, which are that's the word that's used to describe dysfunctional muscle function. So the muscles of that foot or ankle or hand or wrist don't move when when the patient tells them to move. You say, wiggle your toes, and they cannot wiggle their toes. Or they're held in constant contraction in some sort of distorted posture. So that's dystonia. Often it's associated with involuntary movements like tremors.
I didn't think it was going to. Well,
And
I thought it was starting at noon.
Courtney, maybe you want to mute your, thank you. I was talking about dystonias, and then ultimately it's associated with atrophy of the muscles because the limb is not being used, and contractures of the joints because the limb is not being moved. So I think that pretty much sums it up. Dana, anything else you want to ask about that?
No, I mean, that's a really good overview, and I really appreciate the question about if someone blows on it right away, the distinction between just a normal injury and CRPS. Is there any help in a timeline perspective, right? If people show up to you or get a diagnosis sooner, does that help them, or does it really not make a difference when they arrive to a doctor for treatment on this?
Well, speaking of diagnosis, there are diagnostic criteria that have been defined by the Neuropathic Pain Interest Group of the International Association for the Study of Pain. The first criteria were called the Budapest criteria, and then they've been since revised. I think it's now called the Madrid criteria. But it's worth saying that those criteria apply well to adults, but not necessarily to children. And I think the reason is that we usually see children much earlier in the clinic after the onset of CRPS, sometimes within days or weeks, and certainly within months of the onset of CRPS, whereas adults are often seen in pain clinics after many months or even years of suffering from CRPS. And so the criteria don't exactly apply to children, but they do apply to adults. And then to answer your question, I think CRPS is like practically every other problem in medicine or in life. I mean, the longer you delay the initiation of something therapeutic or fixative, the less likely it is and the slower it is to be successful. So if we can jump on CRPS very, very quickly, we're much more likely to turn it around and induce a period of remission or even cure. The longer it goes on, then the less likely it is, or the more difficult it is, and the slower it is to achieve that.
I appreciate that, and I think that will help everybody know, to get to the doctor a little bit sooner and ask those questions right away. Is there any relationship to familial run of CRPS? If a parent has it, is it more likely for their child to have it? Is there a genetic study that's done regarding this?
That's a really interesting question. And the answer is probably yes. We don't know why CRPS occurs in, let's just say, one child in 10,000 or one adult in 10,000 who twists their ankle or sprains their wrist, and it doesn't happen to the other 9,999. I think in the past, we've often just thought about that as random bad luck, that it's occurred in one patient or another. But I think the probability is there's probably a genetic vulnerability. We haven't really discovered that for sure. We haven't done gene studies, gene sequencing to determine if patients with CRPS have a unique or a family of mutations that other people don't have. But there's some clues to suggest that there is a genetic vulnerability. For example, there are certain patterns of CRPS that are associated with HLA blood typing. So HLA system is one of the systems of identifying genetic patterns of mutation. There's actually, it stands for HeLa. Well, I can't remember what it stands for, but it all derives from that African-American woman whose whose tissue, whose blood was banked some time ago, back in the 60s or the 70s. There's actually a great book written about her. But in any case, CRPS that spreads to other limbs, even though those limbs have not been injured, we can see it start in the left leg and cross over to the right leg or go up to the left arm. When that happens, there's HLA blood typing that's associated with patients who have that happen. So that's a strong indication that there's a genetic variable at play here. The other thing is that we see CRPS more commonly in the population of patients with connective tissue diseases, most commonly Ehlers-Danlos syndrome. We see CRPS quite a lot in patients with Ehlers-Danlos syndrome, far more often than we see it occur in the general population, and that's clearly a genetically associated condition. So there does seem to be a genetic vulnerability, but we don't really know exactly what that is. The other thing that seems to occur that suggests strongly to me that there's a genetic factor at play is that we virtually never see CRPS below a certain age group. And typically that would be, 10 years plus or minus a year or two. And we see it way more commonly, 7 or 10 times more commonly in females than in males. So clearly females are genetically different than males, right? That's what determines gender. And so there's clearly a genetic vulnerability in being a female versus being a male. And the fact that it occurs at a certain time of development suggests to me that there's also genes that are being turned on or genes that are being turned off, maybe protective genes that are being turned off, or other genes that are causing the nervous system to go awry that are being turned on at a certain point in development. I'm not saying that, and that's typically around the time of the beginning of puberty. Girls begin to develop secondary sex characteristics at around the age of 10. And that's about the time that we see CRPS starting to occur in young girls. And I'm not suggesting that there's a hormonal influence possible, but I don't think that's the case. I think probably it has to do with genes being turned on or off, as I said, which is what triggers puberty, in fact, genes being activated.
Is there a stress component to this? Because obviously the body's already being taxed when it's going through puberty. There's so much more going on. So how do external factors play into this, if at all?
That's a fascinating question to ponder, and I can only give you hypotheses regarding that as well. First of all, one clue is that we see their anxiety disorders, generalized anxiety disorder, or GAD as the psychiatrists call it, are more common in the CRPS population than in the general population. We see psychiatric illnesses or mental health illnesses more common in that population. And one might argue that, or hypothesize that, well, sure, these patients with CRPS have tons of anxiety because they have tons of pain. And obviously, lots of pain is going to generate lots of anxiety. If you know your foot feels like it's on fire, if somebody accidentally brushes up against it, you're going to have tremendous anxiety about walking down the corridor at school surrounded by other children, or standing in line for a rock concert or something like that, because you never know when the next person's going to accidentally step on your foot. That's very anxiety provoking. But I'll say this, that when we dig in to the history of patients with CRPS, we find that their anxiety symptoms, panic attacks, for example, predated the onset of CRPS. So there may be a genetic link between anxiety disorders, which are clearly genetically determined, and CRPS. Maybe there's a common chemical abnormality that exists in the nervous system with CRPS and anxiety disorders. But there seems to be that genetic link. And then to answer your question specifically, we definitely see CRPS flare during periods of stress. Now, of course, you see lots of illnesses flare if you talk to patients with rheumatoid arthritis or diabetes or asthma or ulcerative colitis. They'll tell you that their diseases flare when they have their final exams in college, or with their boyfriend or girlfriend breaks up with them, or if they get into a big fight with their parents. They'll start they'll start having bloody stools or they'll start wheezing. And so CRPS is no different in that regard. The body and the mind are really, they're not just linked, they're one and the same. And psychological stress is often manifested as physical symptoms, and CRPS is no different than that. I'm reminded of a young woman that we had in the clinic many years ago, a teenager with CRPS, and she would come crutching into the clinic wearing flip-flops, and both her feet would be pink. And her father was a San Jose police detective, a sergeant detective in the San Jose police force, and he was a tough bird, like a lot of cops are. And she had a very difficult relationship with her father. So she would sit down in the clinic and we would be talking about what would be going on, and then I would just casually ask her how her mom and dad were doing, or what was going on at home in terms of a relationship, and I could just sit back and watch her foot turn from pink to blue. All I had to do was ask her about her father, and that would happen. There are lots of examples of that. We've seen limbs go from blue to pink during hypnosis, when states of relaxation are induced. So there's clearly a stress-related component to CRPS.
It's really fascinating and really telling to see how much external factors in parenting, and we're all just doing the best we can, right, as parents and people, human beings, but it really is important to take note that the external influence has an impact. If you can see that right before your eyes, asking simple questions.
Sure,
so
and that's why psychotherapy is one of the three pillars of treatment of CRPS. It's a three-legged stool, and the stool doesn't stay up if you knock out one of the legs. And I can't imagine how anybody would treat CRPS without the intensive involvement of the psychotherapist.
Oh, it sounds like such an important piece of the stool. And, with working with Dr. Zeltzer and working with the CHYP kids, we see the same thing, which is we take a full approach, right? We have a community, we help rebalance the autonomic nervous system, and then we help rewire the brain. It sounds like CRPS has a very similar approach with rewiring the brain and the nervous system to find some stable ground. And then how long do you see that it takes for children? Let's just say, you get somebody in your clinic and now they're willing, they understand this stool approach. They know they have to balance all these different pieces. They're going to do the psychotherapy. And we definitely want to talk a great deal about treatment programs. But before we get there, I just want to talk about, timing of that. Do you feel that it takes years? I know it's obviously really unique to each individual situation and patient, but as a generalized question, is there any type of comment you can have versus how long it takes to see some dramatic improvement for some of these kids?
Depends a ton on a number of factors. And in pediatrics, and I can't speak a lot to adults with CRPS because I don't work in an adult pain clinic, but in pediatrics, age is very, very important. So the younger the patient, the easier it is and the faster it is to treat. And there are difficult aspects of treating a 10 or 11-year-old. A 17 or an 18-year-old athlete is going to be perhaps more motivated to engage in intensive physical therapy, which can be very painful. And it's hard to convince a 10-year-old to do what hurts. But nevertheless, we love to see the 10, 11-year-olds, the 12-year-olds, boys or girls, in the clinic with CRPS because it makes us feel like heroes. We can, in 10 or 12 weeks, we can restore them to normality. And also the interesting thing is, in my experience anyway, that recurrence of CRPS is very uncommon in that population, in that age group. Maybe there's something different. Maybe it's an entirely different disease in a way. But certainly, the 10, 11, 12-year-olds with CRPS are the most fun and the easiest to treat and the fastest to treat, and they don't seem to have recurrence. And then the older you get, the more difficult it gets, and perhaps the more persistent it becomes. So and then there's a lot of variables which have to do with, as I said, motivation, parental support, parental understanding, resource availability in their community, and things of that sort.
Somatization.
Absolutely. I mean, somaticization, and speaking of somaticization, we see a lot of what is now called functional neurological disorder or functional neurologic disorder, which used to be called conversion disorder, which used to be called hysteria. We see a lot of that in the CRPS population. And it's difficult to know exactly why. Perhaps it relates to the perhaps to a genetic linkage between certain mental health conditions and CRPS, but I think probably it's just stress related. We know that the psychologists say that one of the major risk factors or causes of functional neurologic disorder is a severe stress event in a person's life. And if you're a child, it's hard to imagine something more stressful than there are some things that are more stressful, obviously, but CRPS is plenty stressful.
It's very stressful, and I can see what it becomes a chicken versus the egg situation during the process as well. Do you feel that function improves before pain with treatment, or?
Always. And that's a hard pill to convince kids to swallow. We always talk about function first and then pain. And the way I describe it is this, that we'll push kids in physical therapy to the point of maximum discomfort, maximum pain that they can tolerate in that circumstance. It's painful to have a kid weight bearing on a painful limb like that, but we have to have them weight bearing. Of course, we start with partial weight bearing and we build up over time, but we basically push them every time in physical therapy to the most that we can possibly push them to without having a breakdown. And we keep pushing and pushing and pushing. So we keep creating pain and creating pain. But over time, if you look at the big picture, they're from week to week to week, they're doing more and more and more, but we're still pushing them to the same pain point. But we're getting further every time. The example that I use is if you're a golfer and you go to your doctor's office and you say, doc, I have this horrible back pain. I want to play golf, but by the fourth or fifth hole, I have to quit because my back hurts so much. And the doc does something to make you feel better. And you do that and you go back and the doc says, how do you feel? And you say, geez, I still have this horrible back pain. And the doctor says, well, what's your functional level? How much golf can you play? Well, I'm playing 12 holes now, but I still have this horrible back pain. So that's what we're doing with the kids. We're making them better measured by function. Now the guy who used to play 4 holes of golf, now he plays 12 holes before he has to quit. As far as he's concerned, he's still quitting. He can't make it to the 18th hole, the 19th hole, and have a drink. He's still unhappy because he's not finishing the course. But he's better, obviously, and he's on his way to getting 18 holes of golf behind him. But it's hard to get kids to understand that. But that's exactly what happens. Their function improves. And then at a certain point, their function's great, and you can't push them any further. I mean, they're walking a quarter of a mile. That's fine. Or they're jogging on a treadmill. You can't go any farther than that. So you keep them exercising that point, and then the pain starts to diminish little by little, and then they're happy. But it takes a while to get to that point.
It's what we see a lot with our CHYP patients, right? They are bedridden. They are afraid to get out of bed, and our goal is to get them to take a step, get to the bathroom, eventually get to the kitchen, right? Get to the kitchen and cook it. Yeah. And it's these baby steps before you know it. Right. They're retrained and now they're going out.
Stand on both feet when you brush your teeth at night. Don't keep one foot in the air balancing on crutches. Just touch one foot to the ground. That's all. Just don't stand on it. Just touch it to the ground when you brush your teeth. And then next week, you'll put a little bit more weight on it. Then the next week, just throw one of the crutches away and just balance on one crutch while you brush your teeth. And it's literally baby steps, isn't it? It's little by little by little. And that's why it can take 8 or 9 or 10 or 12 weeks or 16 weeks before you get to your target.
And it also goes to show you how much the psychological piece comes into play, and the having doctors involved on that level too, to remind the parents what to say,
Sure.
when to say it. Sometimes we jump in and say, look, you're on both feet, and then they lift the foot back up, right?
Yeah. Yeah, and the psychological piece is so important. And I'm talking about for the majority of children who don't have a diagnosable mental health disorder, right? They don't have a DSM diagnosis. They're mentally totally normal, but that they still need, in that case, the psychologist is a coach, is a cheerleader, is helping with relaxation therapy, which does everybody good, distraction, and very importantly, working with the family, because parents are not, we're not programmed as parents to know how to take care of a kid with chronic pain. It's very anti-intuitive. So if you have a kid who has a busted ankle or appendicitis, putting them on the couch, covering them with a blanket, handing them the Nintendo, excusing them from taking out the trash or stacking the dishwasher, running interference between them and their siblings is the right thing to do. Because in a week, they're fine, right? They're better, they're up and they're back at school and everything's normal again. But if you have a kid with chronic pain, such as CRPS, that's not the case. It goes on for weeks or months or years sometimes. And you don't treat your child like a China doll. You don't put them in a bubble. You have to reintegrate them into life as much as that's possible. But that's not something which comes naturally to parents. You have to teach them to do that. You have to teach them to say, I know your foot hurts today, but let's get out of bed and let's go to the bathroom and do our ADLs and see if we can get to school. And it just, it's hard for parents to do that because you want to nurture and protect your child. And, if you keep them in bed, they don't complain about their leg hurting, but that doesn't get them better.
It's such an important piece. The parenting piece is such an important pillar of this. And I think it's important to go back right now and talk about, what do we do? What's the first line of pain management? Do you cast a limb? Do you not? When do you cast a limb? When do you not? Does that help? If you could walk us through kind of what your baseline approach is, generalized baseline, of course.
Well, you never cast a limb. Never, ever,
Okay.
ever. In fact, we see a lot of cases of CRPS that are caused by casting, by immobilization. There was a really good study done by a pain doctor named Stephen Butler. I remember his name. I'm not good remembering names. I remember his name because we were colleagues at the University of Washington, and he's now in Sweden. And he did a study with medical students, and normal medical students, nothing wrong with them, and he put their arms in casts for 6 weeks. And when you cut the cast off, you see a lot of changes in the limb that look a lot like CRPS. Now, none of those 20 or 30 med students went on and got CRPS, but if you did it to 1,000, I'll bet you one of them would have CRPS at the end. So what do you see? You see increased hair growth. You see dystrophic skin. And I don't know if, I don't know how many people are in the Zoom this morning, or if you're not in California this afternoon, but if you've ever had a cast on your arm or your leg, or if you're of the male persuasion here, and you've ever had a mustache or a beard and then shaved it off, you'll know that when you've exposed the skin to the world again by shaving off your mustache or goatee, which I did some years ago, so I have personal experience with this. I've also had my arm casted after breaking my arm in high school, and when you get the cast cut off, the skin is exquisitely sensitive. It feels really weird and unpleasant to touch it. It doesn't quite reach the threshold of pain, but it's definitely not a nice feeling. You want to protect it. You don't want anything to touch it. So what's happening there is that the nerves, not having been stimulated, have increased the amplitude of the signal, because the central nervous system, the brain, the spinal cord, they want a normal volume of nerve input coming into it. And if you deprive it of that, it starts to turn up the amplifier to get that. Tinnitus, for example, is a good example of this. The ringing in the ears that a lot of people get when they get older, that will become worse if you put earplugs in and protect yourself from ambient noise. So when you take because the brain will start turning up the volume, expecting a certain amount of input coming from the ear nerve, the eighth cranial nerve, and so that tinnitus is a response to that. And so when you cut off a cast or shave off a beard, the nervous system has become sensitized, and then as you touch it and reaccustom the limb to getting that normal stimulation, the amplifier gets turned back down. And that's kind of what happens with CRPS. It's just that certain individuals with whatever vulnerability they have launch their CRPS when they get casted. And so casting is a bad thing to do. It's sort of like, you know, I've heard this so many times, you know, a kid sprains their ankle, they go to a doc in the box, or they go to an emergency room, or they go to urgent care, and you have an adult doctor, and it's not an adult doctor, but you have a doctor who treats adults who doesn't have familiarity with looking at the joint x-ray of a 12 or 14-year-old, which has lots of kind of looks like broken bones in it, but they're not broken bones. And he looks at it and he says, you know, this might be a fracture. I'm not really sure. We'll put a cast on it and we'll send you to an orthopedic surgeon, you know, for definitive care. And then it takes like 2 weeks to get into the orthopedic surgery office. And by that time, the child has CRPS. Sometimes the pain just launches while they're in the cast. Other times the cast comes off and it's clear that there's CRPS. So casting is a terrible thing to do. Immobilization leads to CRPS, and mobilization is the way we treat CRPS. So the last thing you want to do with CRPS, put a cast on it. Can't do physical therapy with a cast on. So, you know, we asked what's the treatment for CRPS. I said there's a 3-legged stool, but all the legs are not of equal length. So it's not really a stool. You can't really sit on it. The strongest, most important leg, that's physical therapy. I think it's true that to say that you cannot get CRPS to improve. You can't fix it. You can't cure it. You can't reverse it without physical therapy and occupational therapy, PT and OT. PT to reactivate the limb, to remobilize it, OT to desensitize it. So those are really, really important. And the other 2 feet or legs of the limb of the seat of the stool are psychotherapy, as we talked about. It's extremely important. And then there's the medical piece, and that's probably the least important. We use medication, but we use nerve blocks, but we use them infrequently. Medication, we probably, in my practice, we use not infrequently, but maybe half the time, maybe 2/3 of the time. Nerve blocks are quite infrequent these days, and we've gone through different cycles. So we've gone through a cycle of saying, well, we need to block everybody and get going with nerve blocks while then we can do physical therapy painlessly. Now we use them less frequently, but there are certain times when nerve blocks are definitely useful. The medications don't fix CRPS. There's no medication that will cure CRPS. The medication is useful for 2 purposes. One is that it can take the edge off the pain. It can reduce the pain. Once in a while, you give somebody one of the medications that we use and their pain is much, much better, but that's not the rule. That's the exception. Usually, it makes the pain somewhat better. Maybe it takes it from a 9 to a 7 or something like that. But sometimes it really helps get the PT done a little bit more effectively. So the medications are useful in as much as they facilitate physical therapy. If they don't facilitate physical therapy, then there's no point in them. The second is that sleep disorders are extremely common with CRPS because it's very difficult to sleep when your leg or your foot or your hand is on fire. It's difficult to fall asleep. It's difficult to stay asleep. The kids wake up all the time. And then, you know, sleep deprivation is a terrible thing. The CIA learned a long time ago the way to break down somebody is to deprive them of sleep. Then you can interrogate them and get them to say anything. Sometimes it's true, sometimes it's not true what they say. But the way to break somebody mentally and emotionally is to deprive them of sleep. And kids with CRPS are just always sleep deprived. So medication is useful to improve the quality of sleep. Sometimes the pain medication is useful because it leads to some sedation, or sometimes we use medication specifically for sleep. And then, of course, as we talked about, there are sometimes children who have significant anxiety that rises to the point of inhibition of the ability to engage in physical therapy or engage in psychotherapy or something like that, and then using medication aimed specifically at anxiety reduction is useful. That's also not the rule by any chance. By any means that happens, but that's infrequent, fortunately. So medication would be the third pillar, but the least important of the three.
Does it sound like you're using medication to help the children actually get to PT so that they'll do the PT, or post PT if it's been over? Well, it sounds like the PT really helps the pain subside, even though it's painful during the process. Is that correct? Because it's almost counterintuitive, but it makes sense for how the nerves are working.
Well, you know, the PT definitely improves function over time, and then ultimately pain reduction over time. But the PT is exhausting. It is absolutely exhausting. And so kids are fatigued afterwards. They're mentally exhausted. They're physically exhausted. I've never had to do PT with a part of my body that hurts a lot, but if you wanted to dig in and read a really good description of what this is like, the author Stephen King, who writes all these suspense and horror novels, was walking his dog once where he lives in Maine, and was hit by a car and had a horrific injury to his back and his leg, and he wrote this really interesting piece that I think appeared in the New York Times Sunday magazine many years ago. And if you look for it online, you can probably find it. But it's an incredibly descriptive and eloquent description of what it's like to do PT when you're racked with pain. It's not fun, but you have to do it, and it's exhausting. So the medication management is sometimes directed towards that. The secondary effects of PT that are less desirable, the pain and the exhaustion.
That makes sense. And they need support. Yeah, that's a very dedicated process. What is the current thinking about ketamine with regards to patients with CRPS?
It depends who you ask. If you ask an insurance company, they'll say it has no role, it's experimental, I'm not going to pay for it. If you ask me, I'll tell you that ketamine is amazing. Now, there are practitioners. There's a couple of notorious ones in the state of Florida, for example. There's individuals in Mexico and in Germany who engage in very, very high dose ketamine, or what is often called ketamine coma. I think it's true that there's no evidence to support that. It's dangerous. I'm not going to go into that at all. But low dose ketamine is a very interesting phenomenon. And by low dose, I mean a dose that does not, ketamine is a very potent analgesic. So it's traditionally a drug that's been used for general anesthesia. And you can definitely put somebody to sleep with ketamine and cut them open and do a surgical procedure and sew them back up with just ketamine. That's the only drug that you need to use. So it's very, very potent anesthetic and analgesic. And it turns out that in very low subhypnotic doses, that is to say, doses that don't take away consciousness, and doses that are even not even sedative doses, it's extremely potent analgesic. And so it's useful. It's useful for CRPS because it reduces pain, especially neuropathic pain, unlike an opioid, which is virtually useless for neuropathic pain. For neuropathic pain, ketamine is a really, really good agent, and it reduces the pain. Now, if it only did that, it wouldn't be a useful drug, because it would be like using it as an anesthetic. You give it, put somebody to sleep, turn it off, and they wake up. So it's great for surgery, but for CRPS, the pain's going to last for 6 weeks. So what good is ketamine? if you just turned it off and the pain came right back. But the interesting thing about ketamine, and I don't think anybody understands, or at least I certainly don't understand why this is that you can give it to a patient, adult or child, for 5 or 7 days in low subhypnotic doses, and they feel really great while you're doing it, and they can do more physical therapy and they can ambulate more, etc. And then you turn it off and the pain doesn't come right back. Their analgesia lasts for 2 or 3 months or 4 months. And I don't know why that is, but it is the case that happens. The other thing that ketamine is really good for, and probably everybody in this Zoom's webinar has heard of this, is that ketamine is used for psychotherapy and is a very, very good antidepressant. And like the analgesic effect, if you give somebody ketamine and then turn it off, the antidepressant effect persists for months and months. We don't know why, but it does. And so because depression/anxiety, which are really two sides of the same coin, are common in patients with CRPS, especially teenagers, I think, ketamine is very useful because it reduces that. And then when we use it in the hospital, we have tried it as an outpatient. It's something we don't like to do as for outpatients, but like in an infusion unit. But when we can arm twist the insurance companies into approving it, we'll put kids in the hospital for 5 days or a week, and we'll use low-dose ketamine. And their psychotherapists from our clinic, whatever psychologist is assigned to them for their clinic, will capitalize or exploit the fact that the child's on a ketamine infusion and go to the hospital and do daily psychotherapy with it. And what we have found is that they're just far more amenable to the effects of psychotherapy. And so the daily psychotherapy is extremely effective. And so the bottom line is that I'm not sure which is the more significant or the more important effect of ketamine. The improvement in mood, anxiety that persists for a long time, and their susceptibility to the benefit of psychotherapy, or the analgesia. I'm not sure why they're much better afterwards, but whatever the case is, they are much better. So we use ketamine primarily, but not exclusively. We use it for patients who are refractory, who have not responded well to many weeks of the physical therapy, psychotherapy, and maybe medication use, and they're refractory and having difficulty, or for the kids who have recurrent CRPS, who are out in the community and they have a long period of remission, and then it recurs, and then we can re-induce a remission of the CRPS with a week of ketamine. So that's our typical model for using it. However, having said that, we have an outpatient sort of day hospital rehab program for kids with CRPS, where they come to our clinic. They're either in the community or they're staying at the Ronald McDonald House if they're from outside the community, and they come for a long 12-week or 10-week period of daily 8-hour-a-day intensive therapy for their CRPS. And we have a waiting list, of course, for that. And what we have found is that sometimes when we have we have to have the kid wait 1 or 2 weeks to get into the program, or 3 or 4 weeks, we'll sometimes kick them off with a week in the hospital on ketamine. And it seems to really, this is completely anecdotal. I have no data to support this, and the only evidence I have is anecdotal evidence for that. But it seems to be something that is really, really useful, especially for the kids who are very, very anxious. We give them a week of ketamine and then put them in the program, and it seems to ease their transition to the program.
It really sounds like the ketamine helps disrupt the pain signals, at least for any period of time, right? It does.
But it's hard to get the insurance companies to approve it. So sometimes, we have some sneaky backdoor ways of doing it to maneuver around the insurance authorization issue. I mean, we can bring kids in through the emergency room for pain crisis and admit them. And then at that point, the insurance company has no say about what we're doing. But we prefer not to do that. And we do only do that in emergency situations. We don't abuse that. To get them in the front door is more difficult, and usually, not always, but usually we deal with a denial right off the bat when we ask for authorization. Then we have to go through peer-to-peer conversation, and then we have to go through letter writing, appeals, and more often than not, we get to yes, but it's time consuming.
And how is ketamine with the neurodiverse population? Have you seen anything with that? Have any real experience in that area?
Yes, we have a few kids on the spectrum. We discharged one just a few days ago. In fact, or a week ago. So it seems to be, well, it's as effective in that population. And because anxiety is really a huge part of the autism spectrum disorder, the high functioning kids, that it seems to be maybe particularly useful in that population because of the beneficial effect it has on anxiety, the mild sedative effect that it has. So it's something that we would use in that population as well.
That's great. And one of our questions that's coming up in the chat is, what about spinal cord stimulator as a treatment when everything else has failed?
Well, I'm not a big fan of spinal cord stimulation, but certainly it's a major leap in the pediatric age group. In the adult age group, perhaps not so much, but it's difficult to do in the pediatric population. Most pediatric pain specialists don't have the skill or the training to place spinal cord stimulators, and so then, for example, I've actually placed them in the past, but when I start trying to pretend I'm a surgeon and make incisions and sew incisions back together in the operating room, I feel like I have 10 thumbs, and I do it so infrequently. I really feel that it should be done by a pro. So, for example, in my practice, I'll turn to a neurosurgeon and I'll ask them to place it for me, and I'll go to the operating room, and if the neurosurgeon will say, well, where do you want the tip to be? And, I'll say, well, let's put it here. And I'll kind of do it on a collaborative basis. But the point is that it's a big deal to do it in the pediatric population. The data, the evidence that it's beneficial in the long term is really not there. And even in the adult population, the studies that I've read have shown that it's effective, but the benefit is not durable. That is to say, it's effective for 6 months or a year, and then it becomes not effective. And now you've got a piece of hardware in somebody. Maybe you can argue that a year of comfort was worth it, but we're looking for longer term benefit than that. Now, having said that, it's a changing landscape. So the technology is getting better and better and better and more sophisticated, in terms of microprocessing and artificial intelligence or machine learning, and rechargeable units, etc. So it isn't to say, I would say that at the current time, I'm not impressed that it's something that I would recommend for the kids, young adults, teenagers that we have that are, say, going into their 20s. But the technology is improving all the time, and it may be that at some point in time they're going to be more beneficial. Now, there's also a new technology called dorsal root ganglion, or DRG stimulators. Those seem to be better than spinal cord stimulators. So in those sense, multiple stimulators are placed at the dorsal root ganglion outside the spinal cord, or outside the spinal column. So that's a technology that looks like it may be promising in this population. And then the other thing that we've been doing with success is that, I mentioned earlier that CRPS type 1 is not associated with a discrete or known defined nerve injury. CRPS type 2 is associated with nerve injury. We have a number of kids with CRPS type 2. Very commonly, it's been associated with specific nerve injuries related to surgical procedures like arthroscopy of the knee, causing CRPS type 2 from an injury to the saphenous nerve or a branch of the anterior tibial nerve or something like that. If we can identify a pathological nerve, we're using peripheral nerve stimulators. Now that's way less invasive than a spinal cord stimulator. It's put in through the skin through a needle. It's very easy to put in. And then it's removable easily because it goes through the skin. And it's left in for 60 days and provides substantial pain relief. Nothing is going to be 100% pain relief, of course, but substantial pain relief, again, sufficient to allow a patient to undergo more vigorous physical therapy. And it's something that often will then allow the patient to avoid a surgical procedure on that damaged nerve.
I really appreciate that. That was a lot of information regarding that. And hopefully the technology will just keep getting better with regards to that, making that easier. But and I know we're right there, but I just want to make sure I cover some kind of the basic things a lot of people want to know about CBD with regards to CRPS. Also, if a child has had a history of any addiction, how does ketamine play into that? Is that okay for them? If you could cover those before we wrap up today, I'd so appreciate it.
Well, there's contraindications to using ketamine, and I would say that substance use disorder, untreated or active and not in remission, would be a reason not to do ketamine, because ketamine is an abusable drug, and on the street it's called vitamin K. There's other analogs to ketamine, and as a street drug, I wouldn't want to give somebody with substance use disorder a good taste of something that they're thinking that they might want to abuse in the future. I would also think twice about using it in somebody with a strong family history of substance use disorder. So I think those are relative contraindications to the use of ketamine. What was the other thing that you asked, Dana, besides
CBD?
CBD, right. Well, CBD itself, CBD is not analgesic. It has strong anti-inflammatory properties, and in fact, it's a very strong it's very strong as an anti-inflammatory against neuroinflammation. So inflammation in both the peripheral nervous system as well as the central nervous system. I don't think we have any evidence to suggest that it's going to be a useful therapeutic agent in CRPS, though. Maybe it has some promise. We don't know that yet. CBD itself doesn't have very great analgesic properties. It has to be combined with a tiny bit of THC in order to have an analgesic effect. And the THC doesn't have to be very high in quantity. Even it can be sub-psychoactive amounts of THC, but you need THC with the CBD in order to have a good therapeutic analgesic effect. So we do have patients who choose to use a CBD and THC. And of course, it's available widely in California without a doctor's letter any longer. And in many states it's available as, for both medicinal purposes, in which case it does require an authorization letter, not a prescription, different than a prescription, but an authorization letter. And in some places, like California and Oregon, Colorado, where recreational cannabis is legal, it's widely available. And of course, you have to be 21 to walk into a dispensary, but that's hardly an issue for a teenager, who can usually find somebody who's over 21 to obtain it for them, and oftentimes that's a parent. The problem is that THC is definitely abusable. We see lots of kids with cannabis use disorder, and as I said, it's when you give them a doctor's authorization, it's an authorization letter. It's not a prescription. I make it as prescriptive as possible, which is to say, I say, okay, I want you to buy 20-to-1 CBD to THC ratio. I want you to buy it from this company because I have confidence in their purity and in their potency, and et cetera, et cetera. But the letter just gets them in the front door. Once they're in the front door, they can buy anything they want that's in the display case. If they give the letter to the person and say, can you give me what Dr. Crane said I should have, that's great. But if they want to buy 100% high potency THC and go home and get high, they can do that. Right? So that's the problem with authorizing or recommending CBD THC, is that you really have no, if I give somebody a prescription for pregabalin and they go in the pharmacy and say, hey, I'd rather have OxyContin than pregabalin. You can't get OxyContin with a pregabalin prescription. But if I tell them to go and buy 20 to 1 CBD to THC, they can go in there and buy 100% THC. Nothing you can do about that. That's the difference between an authorization letter and a prescription.
But it does, for those parents that can manage that situation and make sure they get exactly what you're recommending, you're seeing that that's helpful for those patients? Is it worth getting under those very guarded circumstances?
I used to be a huge enthusiast of CBD, as some people I see who are in the Zoom know, but I'm less so now because of well, there's absolutely no question that CBD fights neuroinflammation, and neuroinflammation is probably a part of the pathology of CRPS, number one. So it may have a role. Number two, it is analgesic with a little THC. And so, that's probably important. Number three, if you use a slightly higher ratio of THC, let's say 4 to 1, then maybe it's a little bit psychoactive, but it's actually a very good way to go to sleep because it's very sedative. And so it provides some great analgesia and sedation and helps kids fall asleep at night. So I'm not ruling it out. I'm not really against it. I'm just saying that I'm very careful with whom I recommend it to.
I appreciate that. And I know we're at time, so if anybody needs to drop off, please feel free. I have one more question before we wrap up, because I want to make sure I cover everybody's. And it's one thing we haven't talked about, which is tremors and any treatments once a tremor sets in with CRPS. If you could cover that, I'd appreciate it.
Sometimes tremors seem to be a manifestation of functional neurologic disorder. So when the patient is if you have severe pain, it's not unusual to have an involuntary tremor, but the fact that you can stop the tremor with distraction, or the fact that the tremor disappears during sleep, is not necessarily indicative of the fact that it's a functional neurologic disorder. Sometimes it is, sometimes it's not. I don't think we treat the tremor specifically. We try to work around it. We treat the CRPS, and as the pain improves and the function improves and the limb is being used more, the tremor disappears. So maybe that does indicate it's functional, but so I'm begging out of the question. I don't treat the tremor specifically. We don't as a team, except by virtue of the physical therapy and the occupational therapy that they're receiving. Now, that may be different to other places. There are medications that are used for involuntary tremor, like maybe beta blockers or something like that treat a fine tremor, but that's not something that I concern myself with, typically speaking.
I appreciate that. And this has been so much information. I think one of the most important things I want to stress for everybody is just the fact of getting the support across the board for both parents, for children, the parenting side of support, which we have groups for. The parents need support so they can be best aides for their children and motivating them, and then everything else. And you've just given us so much information today, Dr. Crane. We appreciate your expertise and your time so much. And thank you for covering in great deal so many topics that I think were important to everybody. So thank you for everybody for joining us. Thank you, Dr. Crane, of course. And I will send it back to Meg to close us out, but it was really a great topic to have covered with you, and so appreciate it.
Oh, you're very welcome, Donna. It's really been fun and a pleasure and an honor to do this.
Yes, thank you so much again, Dr. Crane and Dana, for that informative presentation. And thank you all so much for joining us today and for sharing your questions. This concludes our webinar on complex regional pain syndrome. We'll be posting a recording on our CHYP YouTube channel, so please feel free to share with your friends, family, and colleagues. And please feel free to contact us with any questions you might have. We'll be sharing our next webinar on our website. And make sure you look out in your emails for an announcement for our next upcoming webinar. And that is it. So thank you again to Dr. Crane and Dana.
Okay. Bye,
Thank
everybody.
you, everybody. Thank